what we are presenting actually today in poster 325 is a model that we created. And the model is an assumption of 10,000 patients who are needing allogeneic transplant, who lack match-related donor. So 10,000 patients needing allogeneic transplant for high-risk hematologic malignancies who lack match-related donors. And we had the status quo, which is there is no Omidubicel, there is no expansion. And then we modeled an access to Omidubicel at 5%, 10%, 20%, and 30%. And we examined the access to allogeneic transplant in the presence and in the absence of Omidubicel. So the status quo, 10,000 patients, 60% of them were able to achieve, 60% of them were able to proceed to allogeneic transplant. 40% of them could not proceed to allogeneic transplant. The time to allogeneic transplant was 11 weeks and a half. Now, this is the status quo, no Omidubicel. When we introduced Omidubicel at 20% in this model, the access increased significantly, and minorities had the best benefit from this. So instead of 22% of Black patients going into transplant, that increased by about 70%. And we saw increase in access to transplant in that magnitude for Asians, Hispanics, and about 5% increase in white patients. So access to, and this is only at 20%, so that will increase more with more than 20%, 30% or and even more. Now, this is a hypothetical model that we designed. So this is one of the major limitations of this. But in conclusion, having access to Omidubicel will increase access to allogeneic transplant across all ethnic groups and will improve outcomes across all ethnic groups. And this is basically the crux of this model. So in a phase 3 trial, Omidubicel showed great benefit in increasing the access of allogeneic transplant, especially in minorities, faster engraftment, 20% less fungal and viral infections versus 100 days. It is not FDA approved yet, and it's being looked at as we speak.